Could I invite our panellists to come up, as well as our presenters, Carol, Matt and Elizabeth. We're also going to have John Feneley, the Mental Health Commissioner, and Susan Pearce, who's the Chief Nursing and Midwifery Officer for New South Wales Health, and very importantly, Mr. John Haydon, who is a consumer within our health system, who fundamentally is the canary in the coal mine for all of this for us. So could I have the house lights up just a touch if we could, so I can see the microphones? Same deal as before, although I haven't got Brian and Stephen on stage, so I'm going to have to look for some others to provide the controversy. If you could come forward with questions. While I'm waiting for people to get to the microphones, Matt, tell me, you want to get off your escalator, you're sick of only paying for hospital care. What are you going to be doing on the Central Coast?
So what we're doing now, Rohan, is reviewing our community-based services, particularly around focusing initially on around our adult and aged services, to really get a good understanding of, one, what we do, two, who we're doing it to, and three, how much it costs. We've done some benchmarking with some other organisations who are considered to be leaders around doing that. So we really need to get a good understanding of, one, as I just said, those three areas, and then what's the quality of the care, and three, what's a better way of doing it. Underneath that, we need to collect data, and we're hopefully going to be piloting a system that will allow us to collect data at a patient level so that we know direct costs, indirect costs, so we can start doing some of that, I guess, modelling around opportunity costs and different ways of doing things.
John Feneley, mental health is clearly on the agenda for the new funding arrangements from the 1st of July. How does the Mental Health Commission see the sort of funding models that we're looking at impacting on mental health care and how we improve mental health care in this state?
Well, look, I'm not an expert on this, but I must say this morning's been really interesting in terms of the bit I've seen. And I have to say there's a lot to be said for transparency, but from a lived experience point of view and from a carer point of view, it's all a bit remote, I suppose, from their immediate interests. So I think that if transparency helps us to better understand where the funding's going, that's a good thing. But if that transparency doesn't help us to transfer care into the community and away from hospitals, then that's a very bad thing, and that's something we're very concerned about. So I'm all for making the system accountable so that we know where the dollars are going. We make sure that mental health money is spent on mental health issues, even if it's innovative mental health approaches. And we need to make sure that we keep faith with consumers and carers in that process. So if this helps in that, then I think it's a very good thing. But naturally, we're concerned that at a time when we're looking for reform in mental health, some of the concerns around activity-based funding, perhaps not well understood within the community, are that it won't necessarily support the initiative to drive care into the community. And we all know that, you know, across government, Commonwealth and state, there is this thing about hospitals being the light on the hill that are open 24/7, 365 days a year. And there's a tendency for us all to fall into this language where we talk about healthcare being about hospitals and not about community. Now, I know that that's well understood in this forum, but I think we have to change the language we're using to make sure that we talk as often as we can about what we're doing to keep people out of hospitals. And that will help us to challenge all of these models, I think, for the future.
Thanks, John. I want to ask our other John. We've been doing a lot in New South Wales Health over the last year or two, and clearly there's a lot happening at a national level. Have you noticed any difference in how your care's provided? What's changed in the way you get your health care?
Well, I'm not sure that I would notice the difference, and nor would I suspect any patient or person in the street notice the difference between the funding levels and the type of care they get. What they mostly think is if it's all right and they're fixed and they're back home, they think that's great. That's what should happen. And if it doesn't, well, they think, well, what can you expect? So that's the way it feels. I've heard good news and hopeful news here. I just hope that I live long enough to see it all happen, for a start. And secondly, it does give a feeling of otherness somehow, sitting in a place like this, looking at health workers everywhere. And so that's how a patient feels, actually. You get all these people coming and looking at you, sometimes they introduce you. A recent experience was I got a name band, and a fellow did say he was a student doctor, and he put it on me, and I said, hang on, my name's not Margaret Williams. And, oh, sorry. So that's the kind of thing it feels like to be a patient. Admittedly, since I know there's a policy about introducing yourself, and now at a recent admission for 3 days, I got at least half the people did introduce themselves. I mean, made a real point of doing it. Most of them told me what they were doing. And I did notice, though, the hand cleansing seemed to be a bit lax, only about half or something like that. So I know about these things because, as well as being a patient, I'm a consumer representative, and I know these things. The CEC has been introducing these things, trying to make them happen. But once I start to hear about patient flow, I start to remember a situation I had years ago when I was on a production line for a few months, and there was a fellow standing behind me with a stopwatch. And that alarms me a little bit, I have to admit, because I've also heard about quality, which I think is probably the most important of what I'd be looking for. There was another point that another young nurse who gave me something with that little thing with all your medications in it, and I looked in there and I said, hang on, this one's supposed to be inhaled, not to be taken, and that's what it would have on the box. So in other words, I might never have come out of there if I hadn't been alert enough to see that's what it is. Not all your patients would be alert enough to see that. So obviously there's a bit of supervision needed with people like that. So these are the sort of things that I know about, and I do know that out in the world where people are trying to overcome these problems, that there are barriers between the local health district and the Medicare local. I also know there are a lot of people, because where I come from, fortunately, they have the same boundaries, which doesn't exist in a lot of places. That must make it twice as hard. I know that people are trying to work towards improving and remove those barriers. So I do know there, and that's probably a lot given that we've only got, there's another stopwatch in front of us here telling us how much time we've got. So I know that when my health professionals get together, and they do try to do what they are, and I know from speaking, because I'm a sample of one patient, when we've spoken to 500 in my local district, and generally speaking, they think the staff are doing their best. Sometimes the funding does restrict how well they can deliver care. So that's really my experience and that of other people.
Thanks, John. Di O'Halloran is sitting in our front row and actually should be sitting on the stage, but they're just getting a chair for her. Di, Medicare locals, crucial in how we actually get off our escalator and deliver the right sort of care for people like John where they need them. What do Medicare locals need from New South Wales Health to actually enter into the sorts of partnerships that create the integrated care models that we want to see in our communities?
Look, I think we're very lucky too, as John has said, in that we have a grand partnership between our Medicare local and the LHD, and we've already moved a long way ahead with a shared set of priorities and a shared work plan, and that work is genuinely very exciting. I know that the people I'm working with feel really invigorated by the progress that's being made and the enormous potential. We're barely scratching the surface, and yet we're doing really exciting things with aged care, very early stages, with chronic and complex child and family, mental health, and we already have a strong partnership with ATSI Health. What do we need from New South Wales Health and LHDs? Well, I think we accept that we're working at the margins, and what we're doing doesn't have a lot to do with ABF just yet. It may have in the future. How ABF will facilitate developing very different models of care in the community remains to be seen. It's an unproven exercise, but what is very clear is the potential to move models of care, to rethink the way in which care is delivered, to deliver it in general practices, in community health centres, in not-for-profit sectors, is really enormous. And we are one of the groups that's developing the health pathways, which is enormously exciting. It's far more than guidelines. It gives us the opportunity to bring together consumers, general practitioners, specialists and managers to really work out, given the evidence, given our context, what's the very best way that we can deliver care for this particular group of people with this particular problem. I think one thing I have found to be of great benefit to us is a very clear sense in the Medicare local, in the division beforehand, of what primary health care should look like, what quality practice, general practice looks like, what the principles are that should apply, even if the flexibility is quite marked locally. When I'm working with ACI groups, it's very clear that they are dealing with islands and silos of good quality practice, and they can't, not only do they not understand the primary healthcare sector, but they don't know how to relate to it, they don't have the resources to relate to it, there isn't a system or a set of processes that allows them to really engage with general practice or with others. So I think it would be of enormous benefit if we could all do some shared work. Let's stay right away from the highfalutin visions. Let's just say, what should it look like if we had our druthers? What sort of health literacy should patients and families and parents have? What sort of technology should there be in the home to monitor ill health? What sort of connections should they have with their local GP and their local practice to support them best in the home? What sort of backup should the GP have? Tony Lemke's here, and he'll be in one of the groups afterwards facilitating. If you want the definition of what quality practice can really do at its best, then that's the man to talk to, and I might leave it at that.
Thanks, Di. Thanks. So, Ruth, you've been waiting patiently at the front. Sorry.
I thought you might have forgotten my name, Rohan.
Not at all.
It's been a few years since I wasn't sure. I'm Ruth Arnold. I'm a cardiologist who's worked at Orange Base Hospital in the rural area for a decade, and I'm very involved with the ACI and cardiology in trying to look at best practice and how we roll out across the state. In rural areas, we're certainly hoping that this healthcare reform and funding change doesn't represent a reshuffling of the deck chairs on the Titanic. We must really acknowledge, as I'm sure everyone's aware, there's major challenges across the state because the allocation of resources and the level of care available to patients across the state is not equal. And we must realise that there's a lot of work that still needs to be done to address variations in outcomes on that basis. For instance, the standard of care for treating a heart attack in metropolitan areas is now 24/7 cath lab activation for an acute STEMI, which is a fantastic level of care that everybody would aspire to. New South Wales Health has had a program at addressing that in rural areas, and there are 5 rural cath labs, but not one of them is even operating 5 days per week because of funding-related issues. These are challenges that the system really needs to look at and to drill down into the clinical variation, what can be offered on a cost-effective basis, and how can the ACI and the CEC work together with New South Wales Health to facilitate better care for rural communities and the ability of the local health districts to allow development of locally based services for patients and their families.
Thanks, Ruth.
Thanks.
So is there anyone in the panel who'd specifically like to comment on that?
I guess I'm getting at an equity and access issue, and how do we ensure with the new model the rollout across the state of these types of programs and support the local health districts in achieving statewide standards.
Thank you. Matt, do you want to have a crack? Equity and access issues as a CEO of an LHD, how do you deal with them on a daily basis?
Thanks for that question,
Yeah,
Rohan.
I thought you'd love that.
Look, I guess to be really blunt, It's around, as I said before, the dollar you spend in that unwarranted clinical variation is the dollar that you could be spending in doing something efficient. And I think we really need to take that down to the service level and really get clear understanding of why there is variation, reduce the variation, create the dollars that you've got within your own LHD and invest in the priorities that are determined collectively by clinicians, by the board and by the community. And I think that's really the way to go. There is no more money. So I think there's money already in the LHD, and from my perspective, I want to know why we're an outlier, why we're a variation, and what we are going to do about it with help from ACI and the other pillars, and really free up those dollars to invest in other things. Now, I mentioned before around community and general practice and doing that. There are dollars already there, we just need to do it smarter. So for me, to be really blunt, we have to address that unwarranted clinical variation, free up the dollars, and invest. And I guess the other thing I'd say is be very clear on what we're ready to disinvest in when there's no evidence. We think we've been doing it for 20 years, and why do we continue to do it? Because we've been doing it for 20 years. I think we've got to ask the hard questions.
Carol, you're a board chair and a clinician. What's your take on this? How do boards address equity issues for their population and the clinical variation challenge? Let me give you this.
Look, I think it's a really big issue. Obviously, things like opening a cath lab requires an enormous infrastructure, it's clearly something that does have an equity of outcome component to it, and I think it's not easy with the challenges of distance and transport, with the benefit, given a 3-hour window of trying to get somebody from Orange to a centre that does have it. I mean, we have it.
We do in Orange.
Sorry?
We do have PCI available in Orange now.
Well, sorry, maybe then another centre if you're talking about a different centre or a 24/7 service. I mean, it happens in a broader sense to everybody for, if there's a small number of people who need a service, then how do you fund deep brain stimulation for a statewide service, or how do you fund interventional neuroradiology even in the metropolitan areas? So I guess it does come down to a decision making of, do you do everything for everybody, or do you put your dollars into where you're going to get the best outcome on a population-based structure? It's very difficult because you can't do absolutely everything for absolutely everybody, and so I guess that the priorities is how do you help the most people within that funding envelope. I think it's a difficulty when we don't have limitless funds to do everything that everyone wants us to do. I don't have a good answer. I think there's partnership aspects to it. I think some of the smaller LHDs in population are some of the largest in distance, and partnering with other LHDs that might have access, I think, is important. But then it does come down to the issue about cross-border funding, and certainly if we do things for Canberra, do we get the activity-based funds back, or those sort of things do create that tension that was talked about this morning.
Rohan, if I could
ask one more question, if I could. The one thing that perhaps the system doesn't do particularly well, and this is not just rural patients but outer metro patients and transfer of patients between facilities, is something that we don't examine well. We don't collect the data very well, or the KPIs, and there's a large number of bed days for the whole system that could perhaps be dealt with better if we had a way of looking at those waiting for transfer days to and from or between facilities.
Thanks, Ruth. It's a very important point, and indeed there'll be further good news coming out of our ABF task force in terms of tools that'll be made available to look at that sort of information across the system. So we'll keep people informed of that. Susan, nurses are the foundation of our health system. Our hospitals fundamentally exist for very few purposes other than to provide nursing care. Just about everything else that's delivered in healthcare could be done in another setting. It doesn't require a hospital. In terms of these funding reforms and the fact that nurses our largest segment of the workforce, a big segment of our expense budget. What do funding reforms and indeed the broader health reform agenda mean for our nurses within the system?
Look, I think you're right. I'm sorry, I've got the frog in my throat as well at the moment. Nurses do form a large component of the cost buckets. I think it's something in the order of 34%, but you probably know that better than I do. And when you look at the variation, and the slide that I think Carol put up earlier, you know, nursing does form a large component of the weights. For us, I guess one of the things that we are working very hard on is about bringing things back to basics. And regardless of funding reforms, the funding is one element of it, but I think that the evidence that we see is when we do change things in terms of how we apply nursing care to patients with patients' input, there is an improvement in efficiency and a corresponding improvement in patient outcomes. And one large piece of work that most people here will be aware of is the Essentials of Care program. It's not a panacea for everything in New South Wales Health, but the outcomes from that work shows that simple things like, for example, an orange pillowcase for patients who have a high risk of falls can significantly decrease the occurrence of falls and consequently the length of stay. So we do have, and I'm glad that you know that we've had the opportunity to have the conversation here today about nursing's contribution to length of stay and to models of care, because I think that we've got a lot more to offer working with our medical colleagues and others in the system and management generally. I'm a representative on the Unwarranted Clinical Variation Task Force. You know, I think that we have got a lot more to contribute. So Essentials of Care is one way of doing that, but I think historically nursing and midwifery have been very good at identifying ways of doing things, not always associated with cost. The other thing I think that we should do is ask the staff more at that level, at the ward level, about initiatives that they can come up with that will improve systems and processes. I think there are a lot of people out there with a lot of good ideas.
Very good. Thank you. I'm looking for more questions to come from the audience. Professor McCorn.
I'd just like to give James a chance to explain to us why he presented a funding formula without using the word quality at any time. He talked about having modifiers of the cost price, the average price, based on rurality, remoteness, aboriginality. Are we going to vary it depending on the quality, good or bad, that follows from that outcome of care?
People who have been keen followers of our work will know that in our very initial discussion paper on how the pricing framework should look, did canvass the issue of pricing for safety and quality, which received lukewarm response from various governments and other stakeholders. But we are doing work on this. The simple answer is right now there's no easy way to do it in current systems. But we're working with the Commission on Safety and Quality in Healthcare to explore what the opportunities are. There'll be a literature review has been done, and there'll be a discussion paper released later this year on this topic. Our review of international experience shows whilst there's been some attempts at this, there's no hard and fast evaluation data that shows that it works. But it is something we are keenly interested in and doing some work on. But I have to say, isn't something that has support from all states or territories or even the Commonwealth. There is a strong role for the system manager in this particular aspect, I think.
John?
I came in late this morning, but I got, I think, this last half of Brian's presentation. From my perspective, looking at it from mental health, I just thought it was outstanding in terms of the extent to which it adds a sort of a real transparency in terms of quality and outcomes, and seeing that, imagining all of that being about mental health services, I think would be a great thing. So I think nothing will drive reform more quickly in New South Wales than when we can compare district to district to see what people are doing, because we've got outstanding people across the state doing things, but I don't think we know regularly enough what the comparison looks like between those districts. And there is, I think, I get a sense after 10 months at doing this of great people working really hard, but a sort of a bit of a learned hopelessness about whether or not things can change, and yet clearly quite significant differences between districts in terms of what's happening. So I think that adding this sort of framework and making it transparent, making it public, bringing people with lived experience and carers into that mix and making their views known on a regular basis so that treating teams, whether in hospitals or in the community, are getting that sort of feedback immediately so that we're always looking at that at the same time as we're looking at cost transparency, I think would just help enormously, because irrespective of the more money, I mean, the fact is we can do things differently as long as we're aware enough of the excellent things that are happening in different areas. Could I also add, the other concern I have, just in terms of the funding model, is that the Minister spoke about a new idea, or a new idea at least for adults, around better access to mental health services in the community. And I suppose our concern will be, with all of this activity around activity-based funding, complex discussion around NDIS, is whether this over the next 3 years, 4 years, will actually aid new models of care in the community. Now, for the model he was talking about, I think there are some particular concerns, but also and beyond that, we need to look at the fact that no one model will be applicable everywhere. So if you're out in Broken Hill or in Wilcannia or somewhere, you're not going to get what you get in Newcastle, Sydney and Wollongong. And we need to be honest about that, but we also need to then look at how can we break down barriers in those areas. And I must say, I think constantly it seems to me that we need to keep reminding people this is about the Commonwealth Government and the state delivering healthcare services. It's never about the state alone, and we need to remove all the barriers there are to us accessing Commonwealth dollars and say at a very local level, I think in terms of general practice, we need to be getting back to saying how can we assist general practice to engage with our hospital system? How can we look at recognising them as part of that extended treating team so that we can do everything we can to make it worthwhile for them and affordable for them to engage and provide mental health related services. And lastly, can I just say, I think that we can't afford not to know what the impact on the burden of disease is of all those private services. So I mean, I'd love to see us doing more to help, for instance, private psychiatry to develop better models for being able to demonstrate the impact on the burden of disease they have in this area. And I think if we did that, we might also then look at how we might be able to make some of those services more available in an equitable sense across New South Wales.
Excellent. Thanks, John. We have another question up at the back.
Hi, I'm Chris Laurie from MS Australia. The throat seems to be a thing today. At MS Australia, we have we've been doing some fantastic work with, and starting off with Dio Halloran a couple of years ago with Health One around partnerships with Medicare Local and the LHD. And that's all been fantastic, and the result for us and our clients has been amazing, just in us understanding how to traverse, I guess, the community health and public health system. So I guess one reason for getting up here is to encourage people to engage with those NGOs who provide specific care for a particular group in that chronic complex care program. The other thing I'd like to ask, and I can't remember who it was, but I know somebody mentioned NDIS, and I'd like to ask the panel if anyone's got any thoughts on how NDIS may or may not affect clients who are clients or patients, depending on where you're coming from, who are both accessing a disability services and accessing a health service. We've been asking all along for our people with MS, where does health stop and disability start, or do they both continue on together? So I'd just be interested if anybody's got any particular comments. Thanks.
So does anyone want to take that? John?
I'm happy to say, from a mental health point of view, I have to say that's probably our primary area of concern in terms of trying to get a better handle on the extent to where the dividing line is between clinical care and broader supports in the community. And I think that certainly in the mental health area, it's still very unclear. We hope, in partnership with the Mental Health Coordinating Council, to have somebody in the launch site in the Hunter area to make sure that we can track that over the first 6 months and and get a better idea of how that's going to work and what the barriers that are. I think there's an acceptance, certainly in the mental health, that mental health's come in late and it's not fully understood how it's going to operate. But we want to make sure that within 6 months we've got a much better idea of how it can operate, what services are available, and to try and influence then the rollout across the rest of New South Wales.
The only comment I would make, and living through an experience right now, is with the whole devolution around service provision through NGO sectors and government sectors, we need to be really, really clear on the escalation process and the continuum of care and how that works between the different service providers. And if you don't get that right, it often ends up in a mess. It ends up ugly, predominantly, always for the person involved and their carers, but also for the agencies about how to try and fix it up. And sometimes health is seen as the last resort to try and fix it because, as the DG said, we're 24/7. But I think we need to be really, really clear and have those discussions now at a local and state level about how we manage that continuum of care.
Thanks, Matt. Bruce.
Yeah, thanks, Rohan. Bruce Armstrong, Chair of the Board of the Bureau of Health Information. We've had some very favourable comments made about things that we do now. We're a small organisation, have been around just for a few years. It seemed to me that this was a great opportunity to tap into a body of knowledge on the platform about what you would see in this new world of activity-based funding as the highest priority for public reporting on your performance by the Bureau of Health Information. What could we report now that we're not reporting that you would find useful? And perhaps what could we discontinue reporting that you think isn't helping in the present circumstances? What advice would you give us, please?
So, who wants that?
Look, the work the BHI does is wonderful and well appreciated, and has been the interest of many boards and chief executive discussion meetings at the ministry. I understand emergency department access and surgical waiting lists are necessary evils for service agreements and compliance with government negotiations, and I guess they'll always be there for us. I guess the one area I wouldn't like to stray into is actually costing of information, and I think, as Mary in earlier slides identified, the variance that we've had in 12 months of where local health districts are positioned is problematic. Whether we start shifting to some of the mortality data, which is prevalent in other countries, and how that should be conveyed and interpreted, might start shifting the agenda a little bit to focus on some of those complex issues that are being looked at about specialties and the volumes that are being conducted.
Any other comments from the panel? John?
Also, I would, we've had a conversation about this already, but I would really welcome your involvement in terms of making public on a regular basis much more information about that transition between hospital and community and hospital for people with mental illness. And so that we really can get a very strong sense of what's happening at the point of discharge and keeping track of whether people remain connected to services and can get access to services. And I think we could have a long conversation about what that might be in terms of how it would look in a regular report.
Carol?
I also think the BHI do a great job. I think I'd like them to be a bit braver in terms of putting out more hospital and departmental focused reporting, comparing different departments across different places. And I also think if there could be data linkage that would link with the hospital system, with the PBS and the MBS system to look at broader utilisation, that would actually be fabulous, so that we'd know, we'd get some of the information about if you used more of the primary care sector, did you use less of the hospital sector, or was there an ultimately optimal model that would allow us to actually improve our pathway planning?
Thanks. Susan?
I think just that continuing focus, and perhaps a stronger focus on the volume equal safety data, I think that's really important. And in terms of our ability to demonstrate the reason why disinvestment may be necessary, backed up with solid data, I think is really important going forward.
Here we are. That's a good start, Bruce. Thank you very much. Thanks, panellists. All right, we've run to the end of time for this session. We're going to break for lunch shortly. I'd like you all to have a look at your name tags. If you have a green strip on your name tag, you're due to come back into this auditorium after lunch. Some of you, if you wish to, may be able to transfer into one of the other sessions, as this is the largest session, and we're aware that some people who are in this session after lunch had requested some of the other sessions. So if you'd like to see the reception desk, if you have a green strip, there are potentially places in the workshop on devolution, integrated care, and building pit crews or team-based healthcare. We're going to actually break for lunch but come back a touch early. The important work after lunch is very much aimed at seeking your views of what needs to happen across New South Wales Health as we progress funding and health reform more broadly. So the workshops really are an attempt for you to set an agenda. You'll be given instructions in the workshops. We'd like you to convene in the workshops at 1:40 if you can. It's now 10 to 1. If at 1:40 you could go to your respective venues for the commencement of those workshops. And if you could just join me in thanking the panel. Thanks very much.